we take these, and we know we can never really analyze the case just using the intraoral and the smile view, and then we need to take a series of portrait views, and we draw lines using Keynote or PowerPoint. And first line is the interpupillary line, which gives us the horizontal plane. And you notice that her eyes are not parallel, because she's got her head tilted. And so we transpose that picture, and we do the same thing as we rotate the picture using tools in PowerPoint. So now we have the horizontal. We know that now the photograph we're looking at on the computer is parallel to the horizontal because we've got our eyes parallel. So now everything else that we do from there is we create our digital Facebow on that picture, which is the midline, which we reference by taking an average of the gabelle, the nose, the philtrum, the incisors, the mentum. We decide where the midline is, and then we have a horizontal plane, we have a vertical midline, and with that information, we're ready to zoom into the smile and intraoral views. When you zoom into the intraoral views, we're transferring the facial information to these views. We're transferring, so by taking the vertical, the horizontal reference plane, and we're transferring it now down to the intraoral view or the smile view, we're basically transferring facial references onto the dental references that we're going to be working in. And certainly the midline, we find out where the midline is here on the facial view, and then we transfer it to the same point on the intraoral view or the smile view. And the way this works to the next level of transfer of the information is we want to convey it to our dental laboratory because we don't want those canted teeth. And so whether he mounts it with a Facebow or not mounts it with a Facebow, he wants it parallel to the horizontal. And we, in essence, use the phrase from our menu, is transfer the cross. So we take the cross, 2 points determine a line, we find 2 points that are on this horizontal line, and we put the same line on the cast, and then we find out where the midline is, and we mark it with a pencil. And now the laboratory, we've communicated by doing that with our laboratory where this cast gets mounted with a facial reference as information to give us that mounted. So we can mount it, and so we're basically seeing the facial references on the intraoral and the smile views. Now, what did we do for Jessica here? Her second chief complaint, in addition to my teeth are worn, is that they don't show when basically my lip is relaxed. In order to capture a photograph of this nature, we do the Brad Pitt pose, although that's kind of a movie a long time ago. But in any case, the Brad Pitt pose is if you're, say, at a gas station and pumping gas, and all of a sudden Brad Pitt pulls up and you go, oh my God, there's Brad Pitt. And you just drop your jaw and your upper lip just relaxes. And he looks over at you, and you look like this. You look like you don't have any teeth. And basically, depending on your, well, whatever. Okay, so you want to locate the incisal plane. Well, her incisal plane teeth are up behind this lip. And you applying the digital Facebow, you know you want her incisal plane to be somewhere where you show some teeth. So again, we use the information we got from our mock composite, And the mock composite, we play with it. I mean, you have to add a little bit, subtract a little bit, and work with it. That's what's nice about it, is that you can get it to the point where you can actually give her the amount of display that's appropriate. And you're transferring, now you're basically transferring the dental information, because we did this in her mouth. You take a photograph of it, and you then transferring it to the facial view. So now you're going the other direction, which is what you do in your communication. Sometimes you go from the facial view to the models. Sometimes you go the other direction. And so we now have that information with a mock composite, but we still haven't solved how we're going to restore the case about the vertical. We can use our digital ruler to communicate with the laboratory. If we take a known distance from the incisal edge to the apex of this, the pre-gingival margin, we measure that. We know that's 10 millimeters. Then when you take a digital ruler and you put it, and you can scale a digital ruler any size you want with the scaling on the computer, and you find 10 millimeters on the ruler, and then you don't change the scaling of the ruler, and you put it in different locations. Things that are 10 millimeters will measure 10 millimeters. Things that are 9, you'll get 9 millimeters. Things that are, the width of this central is 8.5 millimeters, that you can measure right off that's the use of the digital ruler. So the digital ruler comes in handy for many clinical situations. If you wanted to know how much did I add on here, you can just take this digital ruler and measure this distance, which is 2.5. And you can say the two centrals are the same, you can measure the length. So the technician is seeing the facial reference on his dental cast. And he can say, then you say, well, give me a wax up. I want you to wax this up according to what we determined in the mock composite. So if he waxed it up, and he had it on the articulator, and he opened up the articulator 2 millimeters arbitrarily, and then he gave you a wax up, and then I go in and I prep the whole case according to his estimation of how to do the diagnostic wax up, basically only on the incisal length. However, then I can give him all kinds of measurements of the incisal length, but I really don't know where the jaw has to be and what kind of posterior support and where the occlusion is going to end up. So we want to do another concept. If you remember our little menu in the beginning, is the concept of test drive. We want to test drive things as much as we can in restorative dentistry. Now it's typical, the saying is test drive something with provisionals. But I didn't want to prepare all her teeth and then decide whether that I've either underprepared the teeth or over-prepared them because I thought I needed more clearance. And then I find out I can open a vertical and I don't have to prepare the teeth at all. So I wanted to test drive the case, and instead of having a diagnostic wax up, which I had but I didn't use, in this case, we took the information from the mock composite, and we made it, and we knew that when you hand articulated the cast, the adapted occlusion, the distance that you measure from this point, an arbitrary point that you'd selected, at the apex of the right central incisor to the apex of the gingival margin on the mandibular incisor. And then when you mounted it on the articulator and you close the articulator down to the first contact, in a retruded position, this measured 14.5 millimeters. So this is this leaf-guided occlusal position is 2 millimeters more open. That's just basically the mechanical difference. It's not necessarily what the neuromuscular is. I mean, is she going to be comfortable if I open her up at 2 millimeters, not prepare any of the teeth hardly at all, because just say I'm going to open her up 2 millimeters? So, what do you think I did? Bill, what would you do?
Did you give her a splint to see if she could accommodate to the increased vertical?
No, but I thought of it.
Did you do direct composites to build up the posteriors and then develop your anteriors?
That's it, Bill. That's what we did.
That's harder.
That was a lot of work.
Yeah.
Let's do the case twice.
That's why I sent it to you.
She came in, this time instead of doing the mock composite, we took, we gleaned from the mock composite and we placed acid etch bonding and we bonded composite all over her teeth, the facial, interproximal, and embrasures and all the contours and everything, but we, on the occlusal in composite, and we basically did her case in composite. And then we said, we're done, no. But we test drove the case in composite. And it took a couple hours to do that and work out the occlusion. And then we took photographs and we established the information that we needed to transfer to our dental laboratory, which I'm not going to say again what a digital Facebow is, but we transferred all that information to the dental laboratory. Then the case became a matter of just doing 3 teeth on this side and 3 teeth on this side, leaving the composite intact of the anterior, and we could establish our anterior coupling in composite and establish the vertical, and it became a case where, and we actually could, and we did, when we built up the composite, she came back in 2-week intervals and we added and subtracted to the occlusion with the composite as needed till we found that we had a comfortable position. And then we prepped these teeth, and then we made these are Emax all ceramic materials. And we're done by a laboratory in California, but then that laboratory moved and all kinds of things. So another laboratory did the anterior. And then we did what is called taco practice. We basically just took off, broke contacts, because we had to open up verticals. We had to do the lingual surfaces as well. We couldn't just do veneers. And that's what we provided her. So I hope this little venture into the clinical area tonight has been worthwhile. And if you have any questions.
Nice job.
I'd like to thank Joel here. I met Joel Richardson, who's a photographer in the back there. I met him in Toastmasters. Did I say? And in Toastmasters, they time you, and they also count the number of ahs. Did I say many ahs?
I didn't hear any, no.
All right. But he's got it on tape, so. And how long did I do?
You were 56 minutes.
All right. Yes. What's that? Yeah, 10 questions. Yeah. I didn't say I'd answer them, but I'll take any questions you got.
Just a comment, I'd like to say how happy Mom is whenever I see her on her recare visits. You changed the family's life, actually, so I thank you for taking that case. And the amount of dedication and work that goes into that is just, you can't imagine it, so thank you.
Thank you.
And I was going to ask you a question now. When you get your bite fork for the Facebow, would you ever think of aligning that in the mouth prior to setting up the bow so that you index it and try to parallel it, rather than taking the canted bow and then doing all this other stuff? In other words, maybe you want to put a little more material on one side and eyeball it when you seat it until it sets.
Yeah, I
just to make it easier.
Yeah,
not everybody wants to play with computer lines. Like that.
Yeah. Well, I have the patient stand up with the bow. They get up from the chair and they stand up and we manipulate the bow so it's parallel. We actually did a digital pantograph on the patient to see that what her jaw movement. Ken Malman got me. We went through a lot of other little things that he mentioned. But yes, that's a great suggestion.
And the second part of that is, did she end up having better feeling on the joint? You said one.
Oh yes, she did.
Okay.
And Dr. Kramer once said, just in that round, which he said to me once, he said that when a patient comes in with joint symptoms, or TMJ symptoms, it may not be the joint neuromuscular or whatever it is, that those conditions that take 2 or 3 or 4 weeks to come on, that they've noticed it, that if you do certain things with the occlusion or whatever, then it might take about 3 or 4 weeks to go away. And those people that come in that have had this condition for 15 years, and you do certain things with the occlusion, you can probably anticipate, as a rule of thumb, that it's going to take maybe another 15 years for it to go away. I mean, it's a rule of thumb, something to think about. And this young lady, her symptoms, I mean, the grinding was almost 4 years, and then the grinding, the symptoms, I think, were in about the last 6 months, maybe 9 months. So it took probably a month or 2 of the mock composite, of the actual bonded composite, till we noticed that she started to get some improvement, and then it wasn't until maybe a year that she reported, after we finished the case, that she reported it was gone.
Does she wear any sort of splint or guard to protect?
We made her one.
She did.
I don't
Whether she
know.
wears it or not?
Yeah.
So, Jeff, what happens with the drugs that you medication like that?
Well, I mean, you make the occlusal guard, but generally, well, first of all, hers was a side effect of a medication. So she, as soon as she heard that it was a something that she stopped taking it. And
Right.
so I mean, I mean,
Walk
I
down
guess,
to see you here.
yeah. So it's, I mean, there's different etiologies for bruxism, and it is. So by reorganizing the occlusion, giving patient anterior guidance and coupling their occlusion, and adjusting their incisal protrusive movements, and things, their bruxism in certain cases can stop. I was thinking, well, I'd like to make sure that they did in this case, because it was drug induced.
Because she's going to have natural opposing arch, right?
Mm-hmm.
So if she continues to grind, what's going to happen between the porcelain and the natural enamel?
Well, the porcelain typically is more abrasive than the. Although with these, there's Emax and there was Empress and Emax. These are restorative materials are getting. I mean, there's feldspathic porcelain, which certainly, when the glaze is worn off, it really wears teeth away. But some of the materials now are gotten to the point where the wear is getting closer and closer to that of the natural dentition. Now, how about a question from someone that came to the topic?
When do you choose to use direct bonding rather than the deprogrammer? You know how the direct composite on it?
Oh, the mock composite?
Yeah.
The mock composite was something you do to demonstrate to yourself and to the patient that you can, that what you have in mind, or that they can see on a temporary basis. And sometimes you put the mock composite on and they wear it home and show it to their spouse or something. I mean, so you would choose it as a temporary measure to demonstrate that you could do a certain thing. The composite bonding was something you put on there. We needed a commitment to the restorative treatment. To spend, it was 3 or 4 hours doing all that bonding, and on her teeth. And that basically is something that that's a restorative definitive procedure. One's a diagnostic procedure, the mock composite.
Well, do you use? You can use deprogrammer like a splint.
Oh, you mean to depro? Oh.
So when do you use the deprogrammer, or do you have a?
I would like. Well, first, the rule of thumb that I would use is the fact that this was a condition with her joint that was something that came on the last, maybe 9 months, right? That came on. It was related to a tooth grind. Or my postulate was that, not my postulate, my conjecture was that the tooth grinding was contributing to her having symptoms of the joint. In other words, there's some patients, you don't see anything wrong with their occlusion, and they have joint symptoms. And those people, when they come in, I refer them to David Keith, and he sorts out what you're talking about, as far as deprogramming. But when I see that there's a dental possible etiology, in this young lady, she had wear, it was short onset, it was like in the last 4 years, the wear, and the symptoms that she was experiencing was in the last 9 months. So if it was dental related, I would think that if I changed to something about her dentistry, I certainly could have used that appliance, but I knew she wanted to fix her teeth. So I knew, and she committed to fix her teeth based from the mock composite. So I was in. So that's why I used the mock composite. But if she wasn't into a commitment to do restorative dentistry, I wouldn't have done I wouldn't have done all that composite work to see if her joint was going to feel better. Right? Does that make sense? Do all that restorative dentistry just to see if her joint gets better, and then if it doesn't, what do I do? And then I'm stuck with all that composite on her teeth. And this composite bonding is something, you do and it looks pretty, but after a while, how many years? It was like 2 years now. That ceramics is there. If I left that composite on there, she'd be back in my office and this chipped and this chipped, and I'd say, Sandra, can you talk to her? Because I don't want to fix it again.
Yeah. Take them out.
Jeff, you gave her some incisal guidance, and you were worried initially about her root structure. Was there any thought of splinting the teeth together, or you left them as single units?
Oh yeah, she had good bone support around all the teeth. She had not the shortest roots, and she didn't have orthodontically blunted roots necessarily, but I felt that for her age, or thought that for her age, that she had a good excellent periodontal support, and that there was not a compromise in her periodontal support for who she was, and that there would be no reason to, in this case, to splint her teeth, because it wasn't, the tooth moved, the teeth weren't migrating. They were solid.
You had said there was initial concern when you initially looked at the case.
Yeah, my concern was I had to know whether this was. My concern was, here's this nice young lady. I'm going to do all this restorative dentistry. Am I going to restore her at the vertical dimension that replaced the lost tooth structure, which means I'd have to prep the teeth somewhat, but some of those teeth are already worn. This tooth here, I hardly have to take any incisal reduction on it because it's already reduced, especially if I know the vertical dimension is closed because the teeth just wore away and the lower jaw came closer up to her nose. But on the other hand, she was an individual with super eruption with her wear, and these teeth had migrated down, and I was now infringing on the freeway space by opening up a vertical, and that was my concern. I had to sort that out before I had to test drive that before I made a big commitment.